So this is Mark East with the South Dakota State Medical Association. I want to welcome everyone to this presentation, Understand MACRA, an overview of the Quality Payment Program. This presentation is brought to you in partnership with the SDSMA Health and the South Dakota Center for Advancement of Health Information Technology, or KHIT. This is our first of 4 programs dedicated to understanding MACRA. Again, we're going to try to keep the phone lines open so that way it can be an interactive presentation. We generally like to try to keep these pretty formal, but if we pick up a lot of background noise or feedback, we'll go ahead and mute those, and then we'll open them up throughout the presentation or towards the very end so you can ask questions. I'm going to turn the presentation over to Mr. Dan Frederick of KHIT. Dan is the Executive Director of KHIT, and he is a Certified Information Systems Security Professional. Dan has more than 30 years of experience in information insurance and adult technical instruction. At this time, I'm going to turn it over to Dan if he wants to further introduce himself and then lead us through tonight's presentation.
Thanks. Thanks to Medical Association for putting this on, and thanks to all of you who are listening for taking the time out in the middle of an evening when there might be a South Dakota football game on. But I appreciate the time, and as Mark said, I'm the director of the Center for Advancement of Health IT, and currently we are on a federal project, Compass Practice Transformation Network, and our goal during this project is really to get practices in a place that are prepared for MIPS and MACRA and the transition from pay for procedure to pay for performance. We're the South Dakota and North Dakota convener for this. And we cover not just South Dakota and North Dakota, but as our whole Compass Collaborative, we cover 8 states, and we're reaching out to about 8,000 providers. So we're in the 2nd year of the program, and I want to let you know we'll probably have some approaching 40 to 45 minutes of content, so we'll have a little time for questions at the end, but certainly feel free to jump in at any time, and if there's any problem with the audio or anything, message Mark to let him know. I can't see the messages pop up, so message Mark, and then he'll handle it from his end. So welcome. You know, we've got a lot of ground to cover. It's interesting how we think everybody knows about this and everything that's coming, but there's a survey just recently came out that roughly 30% of clinicians still don't really understand or have never heard of MACRA and MIPS and what it might mean to them going forward. So actually, as Mark said, we're going to go through this in 4 separate presentations. And the way we'll do that is we'll give a very, very broad and general overview tonight with some specifics of things that came out in the final rule, especially the changes from the proposed rule to the final rule. And we'll cover a few of those changes. But today is really about getting a good broad brush stroke. And then over the next 3 sessions, we will be digging deeper into each one of these areas. So if this is sort of your first blush, MACRA, it'll feel really overwhelming. I promise you that we will get into it. If we've got some folks that are, excuse me, have done quite a little work with it already and have a good sound understanding, I apologize up front for not, if it's some of that first information is too basic, understand that some of your peers may not be as familiar with it as you are. So we'll cover quite a little bit of ground, and I will commit to you because you know the final rule is now about 24, 25 days old, something like that, and it's about 2,400 pages when you get it all said and done. So if you have a question that I cannot answer, our commitment to you will be to review the recording, find out exactly what the question was, and then we'll find an answer for you. So if you have a question, it doesn't matter what it's on, as long as that's on macro MIPS. I'll try my darndest to answer it, and if I can't get it answered, I will get you an answer. So don't be shy about asking. So when we start with this, you're probably the first place you heard about it, right, when macro passed. Everybody was happy that the SGR was fixed, and we'll cover that in a slide or two. They've changed the name already, where initially it was macro MIPS. Now they changed that to the Quality Payment Program, now that the final rule has come out and they've made some other adjustments to it. Really what CMS views this as is they're really saying it's a fresh start, right? And this slide comes right from CMS. So, this is the messaging that they're putting out to us and to take it out to the providers. And I know that sometimes CMS is not always to listen to, because sometimes it feels like, well, they're here to help, but why is this so hard, right? So, like I said, it really is, the view of it is kind of a fresh start. It repeals the SGR, which I think we'll all recognize wasn't working very good. Streamlines a lot of those programs that admittedly added some complexity, things like PQRS and meaningful use and the value modifier. Those things are sort of all rolled up into it, and the reporting requirements are actually getting to be quite a little bit less tenuous than they were in those individual programs. So, I think there's a lot of benefits to that. The idea of MACRA is to move folks into advanced alternative payment models. MIPS is really supposed to be an interim step. So when you think about this steps to a fresh start, the fact that they're saying, that we need to make a change here, I think one of the things that's probably important to see and to think about is actual investment, right? Are they putting their money where their mouth is? And in the case of MACRA and MIPS, are certainly putting a lot of resources into it. So when I look at it, I tend to think of it as, well, they're certainly putting a lot of resources towards moving this forward. And MACRA was passed with bipartisan support when it was passed. So I certainly think that it's here to stay, no matter what happens in the swirl surrounding it. And the fact they have sunk so much money into it, because it's not just right now in the TCPI program, that's an $870 million program. I mean, there are 29 practice transformation networks and support and alignment networks. I know the AMA is one of our support and alignment networks. So they're providing a lot of the messaging and the assistance that as practice transformation networks we need to get this information out there. The scope of this thing is 140,000 providers. There's another $100 million being dumped into MACRA technical assistance for small and underserved settings. That hasn't been officially announced yet. You'll see it, though, in some of the documentation as you begin to look at MIPS. You'll see that there's some mention of this $100 million. Well, it's $20 million a year for 5 years to help the neediest of the needy. So if you feel like you fit into that category, contact through Mark, me, or anybody else that is part of Practice Transformation Networks and can lend assistance to you. But they've dumped a lot of money into the QIO, Quinn School work, and all of this really gets added on top of the National Extension Center work and the EHR incentive program, right? That's the basis for all of these things to build on. So that's about $17 billion. So at this point, CMS is pushing $20 billion making this transition. So they are certainly in it for, I think they're in it for the right reasons, and they're putting their money where their mouth is. So I don't know if there are any proponents out there that are saying, well, maybe this just won't happen. I seriously doubt that. I think I think the die is cast. There will probably be some adjustment in the timing of things, you know, because this is a huge program and it's probably not going to as smoothly as they had hoped from the beginning, and we've already seen that a little bit in the final rule. So we'll talk about that as it goes forward. But I don't think anybody on the phone would deny the fact that sustainable growth rate was not the way to do this, right? Because what they're doing for so many years from 1997 on, you know, was the basic equation for CMS was, well, if it costs too much to provide the care, if that number is bigger than what our Medicare expenditures we want them to be, we'll cut everybody's payments. And that won't work for anybody, right? So they kept kicking the can down the road, and they would say things like, well, okay, we'll let you slide for this period of time, and then we'll make it bigger. The reality was, in 2015, it hadn't done something different. You know, providers were staring at a 21% cut in Medicare payments, which nobody would have accepted. So it was this completely untenable situation. So they went to the drawing board. They got bipartisan legislation to try to get a sustainable growth rate and to try to move where everybody would really like to be into that paying for quality or paying for performance realm. I think that's one of the things that's going to be critical over the coming decades, is to be able to build that in and create healthier populations. And I just know that that's your goal too. So it all sort of fits, right? When you look at MACRA, there's basically two paths that you can go down. There's APMs, advanced, and not all APMs are advanced. You have to have some risk. So they've got to be two-sided risk types of alternative payment models, and we'll kind of get to those at the end of the presentation. But be about these advanced payment models where you as practitioners and healthcare providers are managing risk, and just some of your money at stake, right? So you're managing your risk in that way. MIPS is more of a default position, and it's a place where everybody acknowledges that as you're working towards MIPS and you're not quite ready to be there, this is a way to get you involved with measuring the quality piece, moving that baseline up, and really preparing you for alternative payment models. So would ultimate goal is to get everybody into alternative payment models, and not necessarily through MIPS, but there are, you know, we just recognize, everybody recognizes that there's going to be periods of time where folks aren't going to be quite ready for that yet, right? So, you know, as we look at that going forward, say, well, okay, so how many of these folks are there out there in this universe that aren't going to be able to be ready for advanced payment models right away, right? So the year and the year, there's a subset of providers that are going to be subject to MIPS or eligible for MIPS, depending on how you look at it. And then out into year 3, then another set of them goes and becomes eligible for MIPS. And so the folks that are eligible for MIPS are physicians, and we're using, or I'm not using, but CMS is using Social Security Administration's definition of physicians. So that includes MDs and DOs, doctors of dental surgery and medicine, so DSs and DDMs, podiatrists, optometrists, and chiropractors. Chiropractors are, question? Are only eligible for certain specific subsets of the treatments that they provide. So that's important to keep in mind if we have any chiropractors on the line. The PT and OT and those folks will be coming on out there into the 3rd year of the program. along with clinical psychologists and dietitians and a whole lot of other healthcare providers, that we also move towards this pay for performance area. So a little bit more about this as far as eligibility goes, because, you know, when you start talking about eligibility, there's always going to be differences in how people are visiting with patients and how they're clearing things. So there are some special rules for non-patient facing providers. So, like, for example, maybe a PA that does in an OR, for example, right? They're not doing necessarily patient encounters. So there are some special rules for those kinds of providers. And really, when the final rule came out, they said, okay, to what you classify you as a non-patient facing provider is going to be 100 or fewer visits with patients. So it's up from 25, so that was a good change. So a lot more people going to fall into that exclusion. But for you who are falling into that exclusion, it makes some of your reporting a little bit easier and those kinds of things. So the other thing to kind of keep in mind is that you're going to be able to do either group reporting or individual reporting. And if group reporting, you're sort of all in as a group. You have to go across all 4 of the categories as a group. You can't pick, I want to do group for advancing care information, right? And then for improvement activities, I want to be as individual MPIs. It doesn't work that way. If you choose to do it as a group, you are a group. So those of you who will participate in MIPS, right? So there's a lot of angst about that 10,000. So basically, there's some reading here that if it's your first year in Part B participation, and by the way, if you don't have any Part B participation or any billing that goes to Part B, you are not subject to MIPS. And it doesn't apply to hospitals or facilities that don't do any Part B participation. But if it's your first year in Part B, you don't have to apply. If you have a low patient volume threshold, and then if you are in certain kinds of alternative payment models, you're in certain of those advanced payment models, you are subject to MIPS. So that patient volume threshold is not $30,000 billed Medicare B and 100 patients, right? If you bill more than $30,000 and you care for 100 patients or more for Medicare, then you're subject to MIPS. Therefore, what it says here on this slide is that if you're less than 30,000, you're subject to MIPS, or if you're less than 100 a year that you bill Medicaid for, you're out of the pool of eligible providers. If you fall into this category for any of these reasons, well, actually for the first 2 reasons, if you're in Medicare or the low volume, you can still participate in MIPS, and you won't be penalized if you don't make the cut, so to speak. You won't be in line to get incentives. But as we'll see a little bit later, there's probably some other good reasons to participate in MIPS. You can technically fall out. So, be putting as a group, your group's limits are the same as these, right? So it's like if you have 10 providers in a practice, the limit is 300,000, or 1,000 patients. It's still 30,000 or 100. So that's the thing to keep in mind if you're trying to make a determination whether you want to go group or solo along with this. So if you kind of look at the MIPS timeline, and keep it now that we passed this thing now in April of 2015. rule just came out in October of 2016. The clock starts running on this thing from a performance year perspective on January, so roughly 40 days away or 50 days away, that performance year starts. So they've done some things now for this interim 2017 year, and the final rule came out that really eases the burden for you from a reporting perspective. But the original timeline and the one you can follow, if you choose to, is you participate all of calendar year 2017, you report on how you did, right, by March 31st of 2018, you get feedback from CMS on your performance in that time frame from 2018 through January 1st of 2019, and based on your performance in your calendar year 2017, your adjustments happen in calendar year 2019. So if subject to penalty, your 2019 payments are the ones that are going to get penalized. If you're subject to enhancements, all those enhancements will also come in 2019. So there will always be this flow, and when you think about that feedback period, right, that might be one of the reasons why, if you feel like you're kind of on the edge and you don't have to participate, rules are going to keep getting tougher on this thing. So it might be worth being in and getting the feedback from them during that 2018 calendar year, even if you have to participate because you have an exemption, right? So something to think about. We recommend clearly that people start early and in the system for as long as they can, because I think there are some real benefits to doing that for you. Do we have any questions so far? Mark, give me a call out so I know I'm not talking to air.
I'm fine. So, good, David, thank you.
Okay, good. Well, I'll make the assumption then that everybody is either overwhelmed already or likely saying just get on with it and get to some more detail. So the detail will start coming now a little bit faster, I think. So those of you who might have been putting to sleep, now's the time to pick up and get with it, because some of those next slides I think will catch your attention. So, MIPS is a graduating program over time. It starts out, so again, now we've got these first 2 years, 2017 and 2018, that are where they're performance years, but like in PQRS, where the payment year trailed by 2 years, QPP is also going to be that same way. QPP stands for the Quality Payment Program. I'll be referring to it mostly as QPP as we go forward. Got those couple of years, and then the incentives or penalties kick in. In 2019, they're at 4%. In 2022, they're at 9%. And I've talked to a lot of people. Obviously, not all of your billing is going to be Medicare billing, and you're going to have variable rates for that. But I think most healthcare organizations work on 3.5% to 4.5% margin, somewhere centering around 4%. So it doesn't take a lot of your revenue stream coming from Medicare for a potential 18-point swing to make a lot of difference, right? So I think that's one of the ways you have to look at it, is what could I possibly be leaving on the table out there in 2022 that I have to be prepared for in 2020, and it really starts to build on itself over time. Not only do incentives and disincentives graduate over time, but the rules are going to continually get a little bit tighter and a little bit tighter. So, our recommendation is to get early, to try to be with the program to the extent that you can participate in it as early as you can, because I think this is one of those places where if you're early, you might get to sway the process a little bit, right? So if you're in year one and you can't do certain types of reporting that they think folks can do, it's important for you to know that and for them to know that, because you might have to make adjustments to the program. If you wait for a year or 2 years and they kind of shake out the bugs, then you get into the program and you find out that you can't do it the way they want it done, then chances of really getting any kind of leniency are them, right? So I think there's going to be a window of time when we continue to go back to them and say, you know, it's not working and this is the reason why. And they're going to be receptive to that message in these first year or two. I don't think they're going to be receptive to it if you're thinking you're going to wait out 2 or 3 or 4 years to get started. So it graduates over time. Kind of the way to look at it is in 2019, so now we're focusing only on the penalty and incentive phases here. So 2019, you can have a 4% negative, you could have 4% positive based on your thresholds, right? So there are a couple of things about the law that I think people talk about, but I think need to be realistic about. One is the actual legislation states that there could be a 3x multiplier upward, in effect making it 27% out in year 2022. That's unlikely to happen. And the reason it's unlikely to happen is because it has to be a revenue neutral program, again, according to the law. So, you know, that would mean that 3 times more people would have to be losers than were winners in order to get that kind of a multiplier in there. Just don't see that happening. If you're looking across that blue bar, there is an additional $500 million a year set aside for high performers. I think that this is where, if you're a go-getter, and if you're, you know, if you're really out to get it, there's some real potential here in these early years, because people have said, you know, well, okay, great, I'm glad we got this don't have to do anything year, right? Because there will be some people that don't do anything. But that means basically that $500 million is going to go to a pot of people, right? So consider that, especially when you're thinking about how do I do this. Right? So if you look at the program overall, you've got the penalties, and that's those folks that are falling below the performance threshold. Then you've got a neutral adjustment if you're at or very close to the performance threshold. Anybody above that threshold, of course, is going to get an incentive. And then if you reach an additional performance threshold, then you will get into that bonus money on the top. So a perfect situation for somebody would be to get in the bonus money in a group of small place, right? Or so up front where there's maybe not a lot of people in that bonus area, that would be the time to be in it. Because I think over time that performance threshold is going to be raised, and it's going to be more and more difficult to tap into that pool of available money. So for 2017, from the final rule, that performance threshold is 70. There's a lot of math involved in this, and actually in our next hour, not tonight, but our next presentation, we'll talk about how the scoring works for these different categories a lot. We'll touch on it just a little bit tonight. Bill boon for you guys, of course, this year is the low performance threshold is set at 3. So the way you can fall below a 3 is if you don't do anything, and if you don't do anything in 2017, you will be hit with a automatic 4% deduction, right? Because the bar is so low for to get there that you really need to do something this year. So automatically, if you get to 70 points from the multipliers, you automatically get an additional 0.5% or 0.5% increase above likely to be the 4% increase, right? So you're probably looking at 4.5% if you score above 70. Now, big change that they made. Does anybody have questions about this right here? Okay, we'll move on then. They've already denoted 2017 as a transition year. So essentially what they have said is we're not turning back the clock on this thing. What we'll do is make your reporting period shorter. And so you do have some flexibility in this first year. The start date from CMS's perspective is that you start on January 1 and you do it for the whole year. Right? But they have authorized a 90-day reporting period, and so latest you could potentially start and get the 90 days in and get some positive incentive that would be October 2nd. Now, I've heard that if you do it for the full year, you're not necessarily going to get any more funding than you would if you only do it for 90 days. But you can do it for any 90 days within the period of the year. So you don't have to wait till the last 3 months. But there's kind of a gotcha in there because you only do a 90-day reporting period. Some of these quality measures have a case volume requirement. If it takes you longer to get to, and for most of them, the case volume requirement is 20. Right? So you'd have to have 20 encounters that would generate one of these quality metrics in order to do that. If you don't get to 20 within the 90-day period, then you're going to get 3 points for that. And if you're above 20 encounters, you can range from 3 points all the way up to 10 points for that particular quality measure. So in effect, the longer period of time you can do it, the more cases you'll see, and that improves your score. So while they aren't doing it solely based on time, the whole idea of case volume really does make it so that you'll want to participate for as long as you can in order to maximize. So your pace, right? This is how they figured out how to keep everybody as happy as you could keep everybody, right? So you essentially, and actually, while I'm showing 4 options here, the 5th option is to be in an advanced payment model. But let me just put that out there, unless you're already on the path to being in an advanced payment model, you are not going to make that decision in the middle of November and be there on January 1. Right? So you take that decision lightly. So if you're not already well down the path of being in one of these APMs, you might as well plan on MIPS. And then as you're working on MIPS, then you spend your time getting to the APMs. Right? So the 4 that we'll talk about here are sort of the 4 defaults if you're not already in an APM. And if you're in an APM, you'll know that. Right? So if you're those folks that isn't in an advanced payment model at this point, you can choose not to participate. Right? And so if you do that, you will just automatically, when 2019 comes around, on your physician fee schedule, your practice will get hit with a 4% payment adjustment on every procedure that's billed at Medicare. So that's not participating, right? The next mode over, which really doesn't do anything but guarantee you don't get a penalty, to do what they're calling a test mode, which is you can submit a minimum amount of data. In fact, you can submit one quality measure for one patient. You do one quality improvement activity at any point in 2017, or could do what essentially is meaningful use, hit the minimums of that, and you will avoid that downward payment adjustment in 2019. And you're testing the system to make sure that you can get everything going that you'll need to. understand that there will be quite a few people that take this position. Again, we would counsel against it. I think there are places where you can get some assistance if you want to be further along the line than that. But I do recognize that some people will take it. So there is this sort of floor underneath at where you'll get no penalty. We much rather see people that are ready to do that full year, to partial year, and try to get to it for 90 days. We also recommend that you start your 90-day period before the very end of the year. And I think people who are involved in the MUSE program recognize the value in that, because no matter how many times you think you got it just right, you'll probably learn something when you first try to do it. We would recommend that you set your sights maybe for the second quarter. I mean, we'd love to see you for the full year, but at least give yourself some leeway. And again, just keep in mind that it's a sliding window, 90 days long, so it doesn't have to match up with a quarter or anything. So definitely as early as you can to leave yourself time to fix any problems would be what I would recommend. So there's a couple things that they did during the transition year that I think were very helpful, right? Originally, there was 4 categories, and there still will be the value-based modifier category. That'll come in after, what we're hearing is after this year. So after 2017, the cost category will be coming back, but for the transition year in 2017, and it's certainly possible that they could hold it out for another year. The reason giving themselves this transition year is to find out how people are ready and how the processes will work and those kinds of things. So the quality improvement activities, the enhancing care information, the clinical quality improvement activities, all of those kinds of things are in effect in 2017. And when either 2018 or for sure by 2021, because MACRA says that in 2021, the quality is 30%, the value-based resource utilization or value-based modifier is 30%, and then PIA and other information are at 20 or 15 and 25 apiece. For this current year, for 2017, your score is going to be 60% of your score. And care information is going to be 25, and that's basically what we've all known as meaningful use over the years. A real new one, so quality is like PQRS, and care information is like meaningful use. Improvement activities, those are clinical quality improvement activities, and there's a whole list of them. There's 90 plus things that you can do to start moving your practice forward to a quality piece that counts 15%. So we look at what's going to happen over time to get out to that 2021 year, which really, from a measurement perspective, year 2019, right? So down the line, we've got to get to a point where quality is 30%, value-based modifier is 30%, and advancing care information and improvement activities make up the other 40%. So there will be some relatively significant changes fast as the program gets built up, right? Again, another reason why we think you should get in early, because I'm afraid if after you get behind, it'll be very difficult to catch up. So a bit about the quality piece, and again, we're going to get into these with much more depth over the next 3 sessions. So we don't need to know everything there is to know about them tonight, but I want to kind of get it in front of you. So most of the participants, and quality makes up 60% of your score this time around, right, in 2017. So most participants will measure like 6 quality measures, or can measure up to 6 quality measures. And If you're in a group and you use the web interface, well, you have to report 15 of them. So for those of you who are probably doing the web interface with GPro or something like that, you know that your methods were a little bit more stringent too, right? You can report these quality measures, and there's like 300 plus quality measures to choose from, and you want to document this. If you go to QPP and Quality Payment Program.cms.gov, they have a fantastic website up there now that is so much better than what the proposed rule was. It's not acronym laden. It's very well laid out. They've got a series. You've got all the measures there. You can pick by subspecialty to pick specific measures that will meet and will be germane to your specialty. So it's a great website. Again, it's qpp.cms.gov. And you can go through there and select all the measures. You can see what the expectation is of them. You can see what the weighting value is. You can see all of those things. So it's a good website. You do have to pick quality measures to report on. Nothing different than PQRS, except it's an easier lift for you. Right? In PQRS, you had to do 9, and they had to be some of them cross-cutting measures. That's all kind of out the window, and it's 6 quality measures that you have to do for 2017. So 20% of score comes from advancing care information or meaningful use, as most of you probably recognize it as. It has all those same components, but there again, they certainly lowered the bar on meaningful use, because meaningful use used to be the 15 measures. It was all or nothing. You either made it or you didn't. Here it's a graduated scale, so while you have to do some of the same things you did, it certainly was modification of what meaningful use was. So it was great that they were able to do that. They've gone a little bit further. They've broken it down into, you kind of had 2 options for reporting advanced care information right now in this 2017 year, and it's because of 2014 certified products versus 2015 certified products. So they've got a little bit different question set. So if you are on a 2014 certified EHR, you can pick from a set of measures that really matches up with those 2014s. If you're on 2015 version already, you can pick ones that so fit the 2015 criteria a little bit better. Or in both cases, you can pick a combination from both of those 2 lists. So you can really pick the ones that you best accommodate. And the differences between those 2 lists, as far as the 2014 certified criteria and the 2015 certified criteria, it mostly centers around the way they're measuring your patient in health information exchange, how you're sharing that documentation back and forth, how you're sharing that information. So if you are a member of the exchange, current South Dakota, you've got a lot of advantages there, and you might be able to pick from the 2015 if you're doing 2014 certified product. The final thing that we'll kind of talk about today, well, there's actually a few more things, but the final category, that's 15% here, is probably the one that's the most foreign to most of you, and that is this clinical quality improvement activities. So these are activities that you can pick from, and there are 90 activities, or a little over 90, that they have recognized, and they are things like belonging to a health information exchange, things like being open but available to your EHR 24/7. those kinds of things they view as clinical quality improvement activities because they're more patient-centered kinds of operations, right? So you pick from a set of 90 things that you can accomplish, and remember, for your transition year, you don't, it was originally 6, but for the transition year, you really only have to get 40 points. So the way this list is broken down, it's broken down into medium weight elements and high weight elements. High weight elements are worth 20 points, mediums are worth 10. So if you're a practice, you've got to get 40 points, you have to put 2 20-point high activities or 4 10-point activities. But I'm imagining that most of you, or many of you at least, will fall into the small or underserved categories because they start that small at 15 provider practice. So when you're thinking about that for this first transition year, they're basically cutting that in half. So you can do one high weight activity. One of the high weight activities that you can do, very simple, is build to TCPI. So if you belong to a practice transformation network, the high weighted activity, you've earned your 20 points. That's the maximum that you need to score for 17. So if a rural health clinic, that's the activity. So that gets you to where you need to be, right? So you can maximize your points by doing a couple of really simple things, and get full use out of that category. There are other, if you're a PCMH certified or some other medical home model, you can automatically get full that category. You don't do any of the reporting or anything. Our Medicaid health home doesn't qualify for that because it's not really a different payment model. So you qualify for it, but if there are other specialty type of models that fit like a PCMH does, then those would qualify. A couple of things that are what we know right now is, those savings programs, right? Track One or the LG Care model. So those are also, you score those just a little bit differently. So all these things for this are basically assertions, right? Or you attest that you have done these activities during this window. So that can be done through a qualified registry or your EHR or qualified clinical data registries or different ways to do the attestation. So a little bit about, they're still building the ship as they're floating or flying the airplane as they're building it, as they're fond of saying. Not all of these things have really solidified yet. So we haven't seen a version of the attestation portal, how you'll attest to these quality activities, but they promise us it's coming. So again, now we've spent a lot of time actually on MIPS. I'm just going to take you through one slide here on APM, and that's the advanced payment model side. I'll be able to show you kind of, and you'll know if you're in these kinds of things. If you're not in any one of these models here, you will fall under MIPS. So, if you see your model there, if you're in any of these programs, then you probably already know that. Otherwise, assume you're going to be in MIPS. We'll spend some time with this too, probably not the next session, but the session after that. We'll spend a little more deep dive into these advanced APMs. Essentially for 2017, percent of your revenue is at risk, your revenue has to be at risk, or the potential of returning some 3%. all of these programs fit into that. Some of the others don't. But there's going to be an additional carryover. There's probably going to be a few other that they're going to publish by January 1st. And again, that's a date that they're providing to us, saying there will be a final list by January 1st, 2017. I would see that advanced information, or excuse me, that 8% scheme, if you will, be raising to 10 or 15% by 2022. That's kind of what's been communicated to us as what they're thinking about. So again, this is an example of the rules are going to get stricter as it goes forward. So just the final slide I have here is I want to again reinforce that notion, right, that you have several options here. You can nothing, take the 4% penalty. You can do the bare minimum, which is one clinical measure on one patient or one clinical improvement activity, meaningful use pieces, and what guarantees you is no negative adjustment. A partial year up to 90 days, do all of the things that you would do as if you were submitting for a full year, and would get you into positive territory. Or you can go shoot the moon, if you will, and get above that 70-point threshold, would put you into the bonus money. In order to do that, I know that you'll have to do a full year, but you probably have to do longer than 90 days, right? So don't think most of you are going to be able to generate the volume in 90 days that it's going to take to submit. So with that, that's the last slide I have. I'm a little bit longer than I would have liked to be, but we've got 7 minutes for questions. So I'll open it up, and like I said, if I can't answer it tonight, we'll document it and we will get you an answer.
Mark, I just verified all phone lines are open, so if you have any questions for Dan, go ahead and please ask. Well, no, sometimes it's hard to be the first one to ask a question, so if I can, if you went through this presentation, and I've actually had the privilege of listening to this introductory presentation once before, and even in that, to me, it can be a bit overwhelming. And so taking that into consideration, what words of advice would you have for a group the first time you're hearing this, and the fact that it is probably a little bit like drinking water from a fire hose, what person start, or what would you recommend a person do to start?
That's a great point. You can send me an email directly. We've got people out in the field that would be happy to come and talk to you, and it's part of our responsibility to do. So if you have questions, contact us. We will help you through those. You can call that phone number there. You can get in touch with Mark, and Mark will get in touch with us. Website, as I say, again, is qpp.cms.gov. That's a very good website from an introductory standpoint. I would recommend that you go there and you look up the fact sheet. We've got a couple of presentations on there. Maybe watch those presentations again. It might be presented a little different way. I wouldn't recommend that until you're prepared to do it, that you dive right in to the 2,400 pages of legislation, because it feels sometimes like it's tripping over itself, because it's so weighty. They do have an executive summary that is okay. It's certainly, you're able to glean some more from that executive summary, but the presentations, I think, is where they really shine in their fact sheet. So the easiest thing you could do would be pick up the phone and just call us and let us lead you through it.
Dan, I do have a question that came in here that somebody sent in, so I'll go ahead and read that to you. It says, I am a primary care provider in Yankton, in ACO with Sioux Falls Specialty Hospital. Is this an APM that has risk, or do we need to be looking at MIPS?
My is that you'll have to be looking at MIPS. Are you a next gener? Well, I guess they can't answer me. So if you're not a next generation ACO, an ACO model, depending on how it's worded, probably doesn't fall under an advanced payment model. Again, how it's written. If you are that second cohort or those next generation ACO models, you probably do fall under that category. But we'd probably want to get a little bit more details from that before we come and answer it. Just being in an ACO is not an advanced payment model. Some ACOs are, some ACOs aren't.
And so again, this person could probably call you or your team, and you could step them through.
Absolutely. Yep, absolutely. Because we'd want a little bit more information, right? And then, you know, we could help them answer that question. And the other thing I think that is good about going through you, Mark, or going through us is the ability to ask the question, right? Because we've got some pretty direct conduits up to the CMS folks. So we can really ask them a question and get a response back from them.
Dan, any other questions for Dan at this time? Again, phone lines are open. Or had not dialed in on the phone, you can also type it in the chat with a Q&A, and I'll read the questions to Dan as well. Well, about that, I think a little bit like I mentioned, probably a little overwhelmed. So I'm not hearing any questions or seeing anything pop up at this time. I certainly want to thank you for taking your time to be with us. I want a reminder out to everybody on the phone that the next program scheduled in this series is scheduled for Thursday, December 1st, and that topic of discussion be dedicated to MACRA's clinical practice improvement activities. More things I do want to mention. Tonight's program has been recorded, and as you listen through this, and after you take a couple of days to think about it a little bit, or you back and revisit it or share that link with a friend, we will be putting that information out there, so it'll be available to do so. If anybody is interested in Category 1 CME credits, and they are being offered through Health, and so when you exit tonight, you should be redirected to their website. If not, please contact me, meast@fdsma.org, and I will put you in touch with the folks there to make sure you can get those credits. Before we conclude tonight's presentation, I do want to put out one more request. Are there any questions for Dan? And I'll throw myself out there at this time. Okay, I do thank you again. On the last slide, you have your contact information and phone number out there. I know you had said a couple of times over that if anybody had a question, they could certainly contact you and speak to you and your members of your team, and you'd be glad to help them. So thank you for that. In closing, I wish you all a good evening. And again, next program will be Thursday, December 1st, and it's scheduled to be at 7 p.m. to everyone, and I wish you a good night.
Thanks.